Okay, so this is so companion case. This is Anu's case. So thank you, Anu, for having me show this. Kind of a similar look. So 71-year-old female, abnormal abdominal ultrasound, query liver mass. I'm gonna go straight to MR. So we're gonna start with the liver. Maybe people can say what they see in the liver or what they see on these images. So this is T2, coronal, and axial.
Any guesses out there? I'm seeing some evil gray in the liver. It seems to be going along the portal vein. This seems separate from the biliary tree. So I'm thinking maybe like a portal vein leiomyosarcoma with intrahepatic Mets.
Okay. Anything else on these T2 images that's abnormal?
And
something in the left side of the abdomen. Sorry. Hi, Arti.
Yeah, no, so Gaurav, yeah, a potential Met on the left side, which also Amar sent me, and the Rupa's asking about the pancreas. So yeah, on the coronal, the shape is like, is that the pancreas or is that the adrenal?
Right, okay, perfect. So
is it going along the splenic vein?
Right, so I'm gonna show you some additional images. So these, I'm just showing for the liver findings first, and then I'll show you with respect to the pancreas. So in and out of phase, nothing exciting. T1 pre-GAD, you could see that it's restricting. And then I'm gonna show you here the post-GAD images, going from the arterial to the delayed phases. So some enhancement, less than background liver, maybe some areas of necrosis internally in this component. But you can see that there's other stuff, and as Arti said, in the portal vasculature. Okay, let's look at the pancreas, or what we thought was the additional abnormality. So any observations here? So what structure do we think this whole process is arising from? So T2, axial.
I'm thinking portal vein and splenic vein, like Gaurav said. Amar is also typed in epithelioid hemangioblastoma.
Okay. What organ is this following, roughly?
Pancreas.
Right. Okay. So again, evil gray, as you said, in and out of phase, not very helpful. You can see that it's highly, the solid components of this are restricting. You can see that there's some probably cystic components internally right here.
Neuroendocrine could do this too if it was like replacing the pancreas, and then it can also invade the veins.
And I'm going to show you the post-GAD images here. Okay, notice how it's got a well-defined contour, this abnormality. So I'll tell you that it's arising from the pancreas. Does this look like pancreatic adenocarcinoma? Everyone here has probably seen pancreatic adenocarcinoma. Does it look like that?
Gitanjali is saying IPMN with malignant degeneration, transformation.
And Gitanjali, are you saying that because of the cystic components?
Not answering now.
The shape of the pancreas is preserved. It looks like just distending the pancreas. That's why.
Okay. So how I outlined here that it has a pretty defined contour. Am I trying to say something by saying that? What kind of tumor does that in the pancreas?
I'm still thinking neuroendocrine, which can be cystic. Amar says lymphoma.
Okay. Right, lymphoma tends to be, right, a little bit more ill-defined though. Okay, a rare tumor of the pancreas.
It looks mostly intravascular, right? Or
so
at least
it has a very large
of it.
intravascular component, but it's replacing the pancreas almost entirely. Any other thoughts? Not PDAC, it's not a neuroendocrine tumor, it's not an IPMN with malignant transformation. Rare solid tumor of the pancreas.
I don't know.
Like a spen, like weird spen, but I've never seen us.
Right, so SPEN is a nice thought, and actually SPEN is the differential diagnosis for this. Okay, awesome. So I'm just gonna go on to my slide. So this is an acinar cell carcinoma. which is a rare epithelial neoplasm of the pancreas. If you recall, acinar cells, so they have an exocrine function. So the bulk of the pancreas is composed of exocrine cells. And so what they do is they synthesize, store, and secrete digestive enzymes, so protease, amylase, lipase. It's about 1% of all pancreatic tumors, 5th to 7th decade of life. It has a male predominance, and it's associated with BRCA2 mutation, which interestingly our patient had. The prognosis of this, although poor, it's a little bit better than PDAC, and it's worse than neuroendocrine tumor. There's something called Schmidt's triad, which because of the pancreatic juices or circulating serum lipase, you get this entity where you have subcutaneous fat necrosis, polyarthralgias, and eosinophilia. It's very typical of this tumor, but it's extremely rare. Imaging features. So this is the interesting thing that distinguishes it from PDAC. They're very large at presentation. Typically, they tend to have an exophytic growth, and they have this well-defined margin with an enhanced capsule, which we saw in our case. They typically do not cause dilatation of the main pancreatic duct, which differentiates them from PDAC, and they typically don't cause vascular encasement. They'll often have internal necrosis and cystic changes, and they tend to enhance lower than background pancreatic parenchyma, just like PDAC. The DDX for this is SPEN, basically, so solid pseudopapillary tumor of the pancreas. I believe we saw one last week, which is also a tumor of the exocrine pancreas, 1 to 2%, but that's something that you see typically in young females with second, third decade of life, and they're much less aggressive. Most of the SPENs are benign. Now, tumor thrombus, so I researched this a lot because this is unusual. So basically, the vasculature is completely replaced in our case. It's rare with pancreatic tumors, period. When what you do see it's usually, portal vein, portal confluence, SMV, splenic vein, of course, because of the location. And tumor thrombus for trainees, if you see that, you have to think of these 3 tumors, classic teaching, HCC, RCC, and adrenal cortical carcinoma. I just want to show you the follow-up imaging on this patient, how well they responded. So you also see cavernous transformation here. Obviously, the vasculature didn't recover, but the tumor is basically gone. Just have a little bit of a remnant in the liver. And this is all that's left.
That's amazing. Is acinar usually this responsive?
No, they actually have poor prognosis. But no, just she did really well. They're not. Yeah.
Amazing.
Any questions?
Great case. Thank you.
Awesome. Thank you.
I have a question. Do you know how commonly are acinar cystic or necrotic versus more solid looking like this? That's kind of.
So they often have cystic changes and internal necrosis, more often than not, which is why they say that they look like SPEN, because SPEN is often partially solid, partially cystic. But probably because they're so big, they outgrow blood supply.
Exactly. I think when they're smaller, they look solid, and both SPENs and acinars, as they get bigger, they get more cystic looking, although for the SPEN, it's hemorrhage.
Right. Okay, I'm going to stop sharing.